Okay, Dr. Jo, please.
Hello everyone, I'm Viviana Wonkyung Cho from Catholic University of Korea. Thank you for having us as speakers today. I hope our friendship between Korean and All India Ophthalmological Society keep last for a long time in the future. My presentation title is Rescue Droopy Eyelid Patients. We see various types of droopy eyelid patients in our clinic. Natural aging ptosis, asymmetric ptosis like in the middle photo, or even someone have difficulties in eye opening because of blepharospasm. Those patients progress their droopy eyelid symptoms slowly, so they are somewhat aware of their ptotic eyelid status. However, we're embarrassed when we encounter such a kind of sudden onset ptosis. Then, to rescue those droopy eyelid patients, we need to know what muscles and what nerves are involved to open our eyelids. Let's take a look at the muscle first. There are three kinds of eyelid retractor muscles for the upper eyelid opening. The main eyelid retractor is levator muscle. It arises from the sphenoid bone lesser wing at the orbital apex and passes forward parallel to the superior rectus above the eyeball. After it passes the Whitnall ligament, the levator muscle is changed to aponeurosis and continues downward to its insertion near the marginal tarsal border. The levator is a skeletal muscle which you can voluntarily control. The second eyelid retractor is Mueller's muscle. It is responsible for the involuntary upper eyelid elevation about 1 to 2 millimeters. The Mueller's muscle is sandwiched between the conjunctiva posteriorly and the levator aponeurosis anteriorly, and it is a smooth muscle which you cannot control voluntarily. The third eyelid retractor is the frontalis muscle. This muscle lifts the eyebrow and acts as a weak retractor of the eyelid. Next, let's take a look at the nerves. The third cranial nerve, oculomotor nerve, arises in the midbrain, passes the cavernous sinus. It enters the orbit from the cavernous sinus through annulus gene as two branches. The superior branch innervates the superior rectus and the levator muscle. The inferior branch sends fibers to the inferior rectus, medial rectus, the inferior oblique. And the sympathetic nerves innervates the Mueller's muscle. The annulus gene is a fibrous band continuous with periorbital, and four rectus muscle arise from the annulus gene. The annulus gene divides the superior orbital fissure into the superior and the inferior part. The red circle is the annulus gene, and you can see the superior branch and the inferior branch of the third cranial nerve, and the sixth cranial nerve pass the inferior part of the superior orbital fissure. The frontalis muscle is innervated by the temporal branch of the facial nerve. In summary, among the eyelid retractors, levator muscle is the main to lift the eyelid, innervated by the superior branch of the third cranial nerve, and it is a voluntary muscle. Mueller's muscle is innervated by the sympathetic tone and can lift eyelid 1 to 2 millimeters, and it is involuntary muscle. The frontalis muscle is innervated by the facial nerve. It lifts the eyelid indirectly, and it is a voluntary muscle. To open our eyelids, you can see the different type of muscles are innervated by the different types of nerves. I'll show you some cases next. A 51-year-old male patient came to the clinic complaining of droopy eyelid of his left eyelid. He had DM for 4 years and his vision was 0.7 and 0.9. His pupil size of both eyes were normal. When he lifts his droopy eyelid, his is double vision and had eyeball movement limitation to the medial, upper, and lower gaze. The brain CT and MRI was normal. The pupil was normal as well. As you must have guessed, the diagnosis was oculomotor nerve palsy. It is related with vascular disease, such as microinfarction. Most of the patients are recovered naturally when the microinfarction resolved. However, you should check patient's pupil size. I'll talk about the reason in the next case. 1 month later, the droopy eyelid came back with normal ocular movement without any treatment. Next case. I got a call from the ER because a 63-year-old female patient came to the ER for proptosis of her right eye. She had hypertension as underlying disease. As you can see in the photo, her right eyebrow goes higher than the left, and the right eyelid is droopy than the left. 9-gaze photo shows exotropic deviation of the right eye and movement limitation to the medial, upper, and lower gaze. She took brain CT in the ER and it was normal, but her right pupil was dilated. Taken into together, her diagnosis was oculomotor nerve palsy with pupil involvement. Posterior communicating artery connects the internal carotid artery and the posterior cerebral artery. Parallel to the PCM artery, the third, sixth, fourth cranial nerves run into the cavernous sinus. If PCM aneurysm arises and compresses the third cranial nerve, it can cause third nerve palsy. Then, why pupil is dilated? If third nerve palsy is present with pupillary involvement, there is a higher suspicion of compression because the pupillomotor fiber as well as their vascular component derived from overlying pia course along the superficial superior aspect of the oculomotor nerve. If you see this droopy eyelid patient with pupil involvement, send the patient to the ER within 8 hours. That's very important. Actually, the patient had a coiling history due to PCM aneurysm 8 years ago. Her proptosis might be pseudoexophthalmos due to hypoglycopia of the right eye. During the evaluation in the ER, her vital sign went unstable and mental drowsy. The brain CT was retaken and ICH was confirmed. After emergency operation, she could save her life. It was truly lucky for her that she was in the ER at that time. The last case. 81-year-old female patient was referred to my clinic from GI part for binocular diplopia. She had severe headache and vomiting with anorexia. She complained about her droopy eyelid of her left eye. She had DM and hypertension for 20 years and clot skin cancer operation history 8 months ago. She showed total ophthalmoplegia, ROM to all direction, and pupil dilation of both eyes. Here is her MRI scan. You can see her pituitary is swollen. Pituitary gland is located just underneath the optic chiasm within the cavernous sinus. Laterally to the pituitary gland, third, fourth, sixth cranial nerve pass. If swollen pituitary gland compresses these nerves in the cavernous sinus, total ophthalmoplegia can be caused. Pituitary apoplexy is a condition in which the pituitary tumor spontaneously hemorrhages. Main symptom is the worst headache of my life. Management is refer the patient to NS or endocrinology department. This is the last slide of take-home message. Sudden eyelid ptosis might be a symptom of third cranial nerve palsy. When you meet third cranial nerve palsy, check the pupil first. If third cranial nerve palsy patient has pupil involvement, do not hesitate to refer the patient to the ER. Then, even an eye doctor can rescue a patient's life. Thank you for listening.